All right, let's get right into it. Welcome to this high-yield explainer covering the essential clinical, legal, and safeguarding protocols from RCOG Green-top Guideline No. 53. Now, if you're a candidate prepping for your MRCOG exams, you already know this is an absolute must-master topic. We're going to break down the exact parameters you need to have locked in for exam day, making sure you know exactly how to manage these presentations in your real-world daily practice. So, here is our roadmap for this explainer. We'll be moving through classification and epidemiology, clinical complications, legal and safeguarding duties, gynecological management, and finally, obstetric and intrapartum care. Kicking things off with Section 1, Classification and Epidemiology, let's look at the definitions. You absolutely have to have these World Health Organization classifications memorized. It's basically foundational. Type 1 is the partial or total removal of the clitoris or pubis. Type 2 is excision, which means the removal of the clitoris and the labia minora. Now, for exam purposes, pay close attention to the difference between Type 3 and Type 4. Type 3 is infibulation. That's specifically the narrowing of the vaginal orifice by creating a covering seal. Meanwhile, Type 4 is kind of the catch-all category. It uniquely encompasses all other harmful non-medical procedures to the female genitalia. We're talking pricking, incising, and crucially, genital piercings. Do not let them trick you with that on an exam paper. And when we look at the global prevalence from UNICEF, you'll see it is heavily concentrated in African nations, along with parts of the Middle East and Asia. But here's the thing. Because of global migration, you will absolutely encounter FGM in UK practice. We're talking about tens of thousands of women and girls in the UK who've undergone these procedures. You have to be ready to effectively manage their care. Moving right along to Section 2, Clinical Complications, both short and long-term. The real exam trick here is keeping the short-term acute presentations completely distinct from the long-term chronic issues in your head. Short-term complications are things like immediate hemorrhage, urinary retention, and genital swelling or infection. But let's be honest, as an obstetrician or gynecologist, you're way more likely to be managing the long-term stuff. This includes epidermoid inclusion cysts that might actually need surgical excision, severe dyspareunia, and recurrent UTIs. Think about it like a plumbing issue. Those UTIs are caused by the stasis of urine due to poor flow right beneath an infibulation scar. And of course, you absolutely cannot overlook the psychological sequela. These patients often deal with intense flashbacks, anxiety, and PTSD. Which brings us to a massive topic for your exams. Section 3, Legal and Safeguarding Duties. The UK's Female Genital Mutilation Act of 2003 does not mess around. It's incredibly strict, and you need to memorize these specific exemptions. Basically, FGM is illegal in the UK unless, and this is a big unless, it's a surgical operation performed by a registered practitioner that is strictly necessary for the patient's physical or mental health, or it's done during labor or immediately postpartum for purposes directly connected to the birth. That's it. Anything else is a crime. In fact, it is a severe criminal offense to even arrange or assist in arranging for a UK national or resident to be taken overseas to have FGM performed. Okay, red alert for a classic MRCOG exam trap right here. Knowing the exact difference between recording and reporting. Recording just means documenting FGM for data collection. This is universally required for everyone. You have to submit the patient's personal data to the Health and Social Care Information Center dataset, completely unanonymized to prevent data duplication. Though, you should reassure the patient that it will be anonymized later when it's published. Reporting, on the other hand, is a totally different ballgame. That's a distinct safeguarding action involving the police or social services. You don't just automatically call the police on every adult pregnant woman with FGM. That requires a very specific individual risk assessment. But listen, if you confirm FGM in a girl under 18 years of age, whether you see it on examination or she discloses it to you, reporting to the police is absolutely mandatory. No exceptions. And here is the magic number you need to remember for the test. This report has to be made strictly within 1 month of confirmation. 1 month. We also need to be crystal clear with our patients about re-infibulation. That's the resuturing of the incised scar tissue, which sometimes gets requested after childbirth. It is 100% illegal. The Green-top Guideline is incredibly blunt about this. There's absolutely zero clinical justification for re-infibulation, and it should never be undertaken under any circumstances whatsoever. You've got to establish that firm clinical boundary from day one. Let's pivot a bit to Section 4, Gynecological Management, and how we assess and care for these women. Setting up the right clinical environment is just paramount here. Good practice mandates that you use professional interpreters only. Seriously, never, ever pull a family member in to translate during these sensitive consultations. Also, your services should be accessible through self-referral, and all clinicians need to complete mandatory e-learning on FGM. On the clinical side, you have to offer comprehensive sexual health screening. Because a lot of FGM procedures involve non-sterile instruments, it is crucial that screening for HIV, hepatitis B, and hepatitis C is offered to all affected women. Now, if you're wondering about advanced surgical interventions, here's another highly testable nugget. Clitoral reconstruction is specifically recommended against. Why? Because the current evidence points to totally unacceptable surgical complication rates without any conclusive proof that it actually benefits the patient. Finally, let's wrap up with Section 5, Obstetric and Intrapartum Care. We're going to trace the patient journey right from that very first antenatal booking visit, straight through the intrapartum period, and finally into careful postnatal follow-up. Step 1, the booking visit. And this is your absolute golden rule. You have to actively ask every single pregnant woman about a history of FGM, regardless of her background or where she's from. This is all about early identification so that a clearly documented care plan can be agreed upon early on with a designated consultant or midwife. When it's time for delivery, consultant-led care is generally the recommendation. If you need to perform intrapartum deinfibulation to facilitate delivery in, say, a type 3 patient, you can actually do this quite smoothly under a local anesthetic right there in the delivery suite. Oh, and if labial tears occur, just repair them in the exact same standard manner as you would for a woman without FGM. But what if your patient ends up having a C-section and you completely bypass the planned deinfibulation? You definitely cannot just discharge them and forget about it. Postnatal follow-up in a gynecology or dedicated FGM clinic is an absolute requirement. You have to make sure deinfibulation can be offered before any subsequent pregnancies happen. So, as you gear up for your MRCOG exams, and honestly, more importantly, as you're out there caring for these women in your clinics and delivery suites, I want you to ask yourself, how are you going to bridge the gap between providing compassionate, culturally sensitive care and strictly adhering to these mandatory legal frameworks? Really understanding the exact parameters of Guideline 53 is your first step. Keep these definitions, your legal duties, and these specific care pathways front and center in your mind. Thanks for joining me on this explainer, and best of luck with your prep.